everyone. Welcome to today's launch event for Lunch and Learn Empower Hour. This is part of our programme of equality, diversity and inclusion events. And the first one today is really trying to contextualise what equality, diversity and inclusion is in general practice. We'll cover microaggressions and then also look at reverse mentoring as well. I'm Shala Imtiaz Umar. I'm a GP, but also EDI Director for GP Task Force, and I'll be joined a bit later today by Dr. Komal Raj, who's also a GP and the EDI Fellow with GP Task Force as well. So the purpose of today, as I said, was to think about EDI in the context of general practice, look at microaggressions, what they are, what you can do if you see anything like that, and then also cover reverse mentoring during the course of this hour. So by the very nature of what we're discussing today, there may be some slides that contain language that could be potentially offensive and also upsetting, but it's really to try and exemplify the situations that staff face in terms of racism within general practice. So thinking about the context, so we'll start off first of all with looking at RES. So this is the NHS Workforce Race Equality Standards. It's based on 9 different indicators and really is an insight into the levels of race equality within secondary care. So it's always been focused on NHS trusts. And the most recent report has actually been published this morning, which I've not had a chance to read, but I would certainly recommend reading that to try and understand the wider context of racial inequalities within the workforce in secondary care and how that can translate into primary care as well. And then a couple of years ago, there was the Medical Workforce Race Equality Standards that really looked at the impact on the medical workforce regarding racial inequality with respect to progressing through training, the difference in being appointed to a consultant, the levels of discrimination experienced by medical workforce from colleagues, but also from patients. And recognising that actually both of these two, significant reports were not covering the issues felt in general practice, local teams had a look at what was going on within their area. So Humberside was one of the first publishing their racism and discrimination report back in April 2021. And this was preceded very shortly, just pretty much around the same time, by Doncaster. And then in November 2021, the Leeds Whole General Practice Workforce Survey report was published. And during the summer of 2021, the Derbyshire General Practice Discrimination Survey went out and the report was published in December 2021. And for those people who haven't read it and would like to have a copy, then get in touch with the office or myself, and I'm very happy to share the results of that report with you. Essentially, all of these reports are showing that there is an issue with racial discrimination within general practice, but also within secondary care. And this is not affecting just clinicians, but also non-clinical staff as well. And more recently, the London primary care team actually looked at, again, experiences of racial discrimination and harassment. And more recent media reports have been around doctors facing high levels of racism in the NHS, which is only exacerbating a debilitating problem with regards to recruitment and retention. And in the last several months, the BMA also published quite a significant report regarding racism in medicine. So when you're thinking about this, and particularly in times of where we are as an NHS service with respect to the pressures we're facing, the demands we're facing, and the lots of, the clinical complexity of the situations we're facing, it can become a case of actually, so what? And it's important that we actually put this in the forefront of actually why is it important that we're looking at equality, diversity, inclusion, particularly in the face of some of the media challenges that are being put forward with respect to the concept of EDI within the NHS. And as those reports have shown, there's ethnic minority disparities in the workforce. So previous surveys have shown that 45% of staff feel that there's a lack of response for diversity, there's no culture of inclusion, and the lack of visible leadership from positive role modelling at leadership level means that those ethnic minority disparities are only further exacerbated. We know that ethnic minority staff members are more prone to increased bullying and harassment, and that's not just from colleagues, but also from patients as well. And that lack of progression means that staff are, not going through their careers in the way that they want. And this is, again, not just clinical, but also non-clinical staff. In terms of medical education and career progression, repeated reports have shown that there are attainment gaps and that there is a pass rate disparity. So for some exams, you know, particularly in terms of GP, Black, Asian and ethnic minority colleagues are more likely to fail by 4 times more compared to white colleagues and peers. And if you're an international medical graduate, you're actually 14 times more likely to fail your exams compared to an ethnic minority doctor who's been trained in the UK and also white colleagues. And that disparity really, again, reflects the lack of positive role modelling who are progressing through the career in order to help those colleagues more junior in their career. And during COVID, we have become increasingly aware of health inequalities and the impact of COVID on our communities. So normally socioeconomic factors that impact on health inequalities includes lack of education, unemployment and also poverty. But putting that into the context of the medical workforce, we know that 95% of doctors who died in the first month of lockdown were actually doctors from an ethnic minority. And 85% of all doctors who died during the COVID pandemic were from an ethnic minority background. And this group of people are actually not affected by a lack of education, they're not affected by unemployment, and they're not affected by poverty. And that really then raises the question of actually why were these ethnic minority workforce colleagues more likely to die in COVID rather than their white colleagues? And you know, one of the reasonings for that we have to accept is that there are structural inequalities within the workforce that meant that our colleagues were more likely to die based on their ethnic origin. And when you put all of this again into actually, so what, you're thinking about if this is the inequality being faced by our colleagues in the workforce, what impact is that having on patient safety? And there's a plethora of data out there showing that racism within the workforce translates into poor patient care. It becomes a patient safety issue because those racist attitudes and those discriminatory behaviours impact adversely on our patients to the point that they don't receive the care in the manner and the way that they should do. And that obviously impacts and further exacerbates health inequalities. And thinking about the weathering hypothesis, this is looking again at patients, the chronic exposure to socioeconomic disadvantage, to those patients who are marginalised identities, increases the discrimination and it leads to early health deterioration. So this, this picture is really trying to illustrate the point that if you're a Black or ethnic minority patient or colleague, you're more likely to face racism, alienation, unfair access, prejudice, which causes a deterioration in your health, and whether that's physical health or mental health. So moving on to aggressions, I'm going to open it up to the floor. So this is hopefully going to be an interactive session. Does anybody know what a microaggression is?
I think isn't it those areas of work and life where things appear very minor, small comments, small actions, almost the nuance of what's going on, the kind of non-verbal aspects sometimes of relationships and approaches to things.
Yeah, absolutely. So micro is essentially obviously denoting the fact that it's what can be seen as a very small throwaway comment, and as a couple of people have said in the chat, it can be reflective of a stereotype that we have, or an everyday throwaway comment, but actually that does have an impact. So when we're thinking about microaggressions, it is essentially defined by being a commonplace, and it's a verbal, behavioural or environmental indignity. So the verbal microaggressions can be things, what we consider to be simple things of where are you from? So as an ethnic minority doctor, I've had countless situations where I'm asked, where are you from? And that in itself can actually denote otherness. So, are you saying that I don't belong in this society? Do you think I don't belong in this role? And therefore you're questioning, where is my origin from? And, if you're talking to Muslim women, for example, in the summer, very commonly we're asked, are you not hot in that, in reference to our hijab? And that actually is a kind of verbal as well as behavioural indignity that's placed on a certain group of people. So behavioural can be situations of, if you're, for example, a black person is walking down the road, somebody crosses the street, somebody clutches onto their handbag. Those are kind of microaggressive behavioural microaggressions that denote a stereotype that's actually offensive to black people in terms of the stereotype that's being placed there. And environmental microaggressions can be denoted by, statues or buildings that are named after figures that have been heavily involved in either racism or genocidal activities and behaviours. But essentially, they all communicate hostile, derogatory, or negative, prejudicial slights and insults to any group, whether that's based on somebody's race, ethnicity, whether that's based on anybody's overt religious affiliation, or based on sexuality that may be obvious in some way, gender, or any other protected characteristic. And the microaggressions can be insults, they can be gestures or insensitive comments, but essentially they're all rooted in a stereotype, as somebody said in the comments. And they can be remarks, questions, or actions. So as I was saying earlier about verbal microaggressions, they can often be, a compliment, such as, "You speak really well for an Asian person." So again, that's rooted in a stereotype that's actually quite offensive, but it's, kind of portrayed as being a compliment or a joke, and they can often contain a hidden insult about a group of people, and they happen really casually, and they're seen as a bit of a small incidents that can be brushed under the carpet, and they are seen as intentional but mostly unintentional as well. So to summarize that, they are subtle, they are mostly unintentional, and they can be ambiguous. It coming back to what Gail was saying, they can be seen as, actually, is that something that is actually happening, or is it not happening, or you're not quite sure, you can't quite put your finger on it. It's not as overt as calling somebody a derogatory racist term, but there is an intention behind that. And the different types of microaggression can then be further broken down into micro assaults, micro insults, or micro invalidations. And these are, micro assaults can be discriminatory verbal abuse, but it can also be a non-verbal action as well. And it's essentially, avoidant behavior or perpetual kind of discriminatory action. So a common, trope is that black women are angry. So to say something like "stop acting like an angry black woman" is again a microaggressive behavior. Or "why can't you people ever listen?" So again, referring to a certain group of people, and an offensive language, and it can be overtly, "why do I get a dumb black nurse?" And those are comments that our colleagues have absolutely faced within the NHS. And micro insults are insensitive and disparaging comments, so they're not necessarily an assault, but they will be an insult. So referring to minority colleagues as those people, and potentially referring to them that they've received or obtained their current position of either leadership or progression through their career because of affirmative action at the detriment of the dominant identity within that group. And a micro-invalidation really has come more, to the fore, particularly after the Black Lives Movement, when people felt that all lives matter and white lives matter. And that really is trying to invalidate the feelings of a large group of people, so the black community, who has been disproportionately discriminated by law enforcement officers, by health structures, by the justice system, by mental health services. So you're invalidating a massive group of people by saying, actually, do black lives matter more than all lives and white lives? And what you're essentially doing is invalidating the experience of a whole cohort of people. So the microaggression messaging is really actually, when you're asking these questions, what are you actually saying? So, what are you? You speak English so well. What do your people think about that? You're really handsome for someone so dark. These are all examples of racial microaggressions. And again, microaggressions, can be based on anybody's protected characteristics. So whilst I'm focusing on race today, really you can put these microaggressions along to somebody's gender, you can put it on somebody's ethnicity, their status in terms of their sexual identity, as well as their religion. So all of these are actually, the comment themselves may seem, well, actually, is it really that much of a big deal? But what is the message that it's sending? So, these kind of questions and comments can convey a message of otherness, that you don't belong here, that you're a foreigner, the identity is not relevant, you're not somebody who's on equal footing or a level as somebody else. So I'm going to share a video now, which is quite a powerful one in my opinion, but hopefully you'll be able to really understand a bit more about what the microaggressive behaviour can look like. Can everybody hear that? Has anybody got any thoughts about that video they'd like to share? So that really is a video demonstrating the behavioural microaggressions that people from a Black and ethnic minority background may well experience. So that is an everyday occurrence of feeling like you're somebody else or othering a whole group of people because of their appearance, actually not recognising the value they bring to society and their local communities. So thinking about intent and impact, often when you or when anybody talks to somebody or challenges a particular behaviour, it can come across of actually I didn't mean it in that way. And we really need to take a step back and think about actually your intent may be one thing, but the impact of that is going to be something very different. And that comes back to the fact that when we judge ourselves by our intentions, but we judge others by their actions. So no matter what your intention is, it's really important when you're asking that question, actually, what is the impact it's going to have on the person who's listening to that, either that comment or that question, or even that interaction. So it's really just something to think about. So this is, we're going to need some group participation here. So just thinking, we're a small enough group, hopefully, to be able to do this, opening it up to the floor, thinking about microaggression, a reflective behavior kind of exercise, to think about a time when you've seen a microaggressive behavior at work. And it's really to think about, did you or anyone say anything to the instigator? So the person who's perpetuating or saying something that's a microaggressive comment or behavior, what could have been said and what was said, and thinking about the target of that microaggressive behavior or comment, what was said and what could have been said. And when you're thinking about these kind of situations, what are the challenges and benefits of saying something to either party, and how could you lead by example? So just thinking, while you're giving yourselves an opportunity to think about that, I'll share an experience that I had, which was a microaggressive behavior from a patient. So this was a patient who was being palliated, was admitted onto a hospital ward because of a complication of his cancer. I was the night SHO and was asked to speak to him because this patient had asked that he actually be resuscitated. So he had a community respect form in place that he was not for resuscitation, came in with a complication and asked that the respect form DNA CPR be rescinded. So as the SHO, I was asked to go and speak to him about this, to understand a bit more about what his rationale for that was. And on my arrival and after introducing myself, his comment was that I don't want to talk to you. Your religion is about killing people and my religion is about saving lives. So that is a microaggressive verbal insult as well as assault, I would say, based on a prejudicial and stereotypical view of a whole group of people based on their overt religious affiliation. And there was a nurse who was present at that time, so I was the target and the patient was the instigator, and this was a witnessed interaction. However, the person who witnessed it said nothing to the patient and also said nothing to me as the target. So there are multiple examples that patients or people could give from an ethnic minority background regarding a microaggressive behaviour, particularly looking at racism. And there may have been microaggressive behaviours that people have seen at work based on a different protected characteristic. So you may not have been affected by a particular racist incident, but can anybody share any examples that they've had or want to share regarding microaggressive behaviours? So somebody's put patients refusing to see certain doctors as they don't speak good enough English. Yeah, so that's a really common one, and that's particularly been a theme that the general practice discrimination reports have shown on a number of occasions, is patients stating that they won't be seen by a certain person or a certain member of staff because of a perception that that member of staff is either less qualified or less trained to manage the issue compared to a white member of staff. I think somebody put their hand up. Rima, do you want to come in?
Hi.
Hi, hello.
Yeah, so there was one instance when I was on psychiatry. I'm a GP trainee, so I was doing my hospital rotations, and I think it was a night shift, and I wear hijab, obviously, so I look a certain way, and there was another doctor there, or nurse or something. She was also wearing a hijab and she looks a little bit similar to me, but not really, like facially. And then, so I was speaking to her, and then I think I left the room, and this other, there was another nurse assistant there or something. So he came in, and then he thought we were the same person, even though we don't look the same. We were wearing different coloured scarves and everything. But I felt that was a bit, and then he said, "Oh, I thought you were the same person," in front of both of us. And at the time, obviously it was a night shift, so you're not really thinking that straight. So I didn't really say anything, but I did think it was a bit of a microaggression, because confusing someone for someone else just because you're dressed similarly, I think is a bit, yeah, and especially, it's like a religious symbol. So to kind of comment on it, I found it a bit offensive at the time.
Yeah, so our appearances cannot, be subject to microaggressive behaviours or verbal aggressions because of a perception or a stereotype. So it doesn't come just down to overt symbols of religious affiliation like the hijab. It can be, wearing a cross for our Christian colleagues, or the Star of David for our Jewish colleagues, as well as, the colour of our skin or the way that they would dress that may indicate, our ethnic background because of the dress that we wear, for example. So has anybody been in a situation where anybody actually said something to the instigator? So for my colleagues who may not have been the target of a microaggression, have you been in a situation where you've actually said something to the instigator? Or do you feel you can't say something because you don't know what's going to come out? So that can be a reflection of actually not knowing what to say and how to say it, because there are challenges in coming up with kind of a framework of how to go up to somebody and say what you're saying is inappropriate. So I'll go through actually what can be done in the situation that you're witnessing a microaggression. So for the target of that microaggression, what you're trying to do is validate their experience. So if you witness it, it's saying things like, "I also noticed that comment and behaviour," and it's the opposite of gaslighting. So for the example that I gave, I spoke about it with colleagues, and the response actually pretty much all the time was, are you sure they meant it in that way? Are you sure you weren't being sensitive? The patient was unwell, so, you know, give them a bit of slack. So actually, you know, yes, the patient's unwell, but where do we then say that that kind of behaviour is acceptable? How unwell do you have to be to say that this is acceptable or unacceptable behaviour? And what you're essentially doing is valuing the person by acknowledging that what has happened is a true reflection of what's happened to them and the impact it's had. If you don't have that valuing of that person and validate their experience, what you're doing is othering them again. So you're putting them at a level where you're not caring about their experience, but you're also, you know, not affirming their group identity. So, you know, what you want to do is try and get that target of the microaggression to feel as though they actually belong within that group, and therefore you're demonstrating an inclusive behaviour. When it comes to how to speak to somebody who's the instigator, if you're the instigator of that behaviour and somebody comes up to you and says, actually, I think what you said there was probably inappropriate, it's really important that you actually listen to them as well. So if, for example, you know, I've done something that has been offensive to a certain group of people, and somebody comes up to me, I would hope that you know, we should be actively listening, let that other person talk first before responding. And it's really important not to be defensive or make excuses. So if I was to challenge somebody within this group and say, actually, what you said on such and such occasion was something that could have been offensive or was offensive to X number of people or to this, you know, group of marginalized part of society, it's important not to be defensive and make excuses. So don't go back to intent versus impact and say, well, I didn't mean to say it that way, and, you know, they're just being overly sensitive, and, you know, why is that such a big deal? It's really important to actually understand the hurt that's been caused, because, you know, we do live in a society now where increasingly offensive comments are labelled as being under the banner of free speech. And yes, it's important to protect, you know, the civil liberties that we have in society and the protections that we have, but we also need to be cognizant of the fact that free speech comes with responsibility and understanding that our words can have an adverse impact on somebody, and how that can, you know, further perpetuate inequalities within our society. And if you're genuinely not sure, then ask and say, what is it that I said that was offensive? Because I don't want to do it to you and I don't want to do it to somebody else. And there's nothing wrong in asking. That nobody's going to say, well, surely that's obvious, because if you don't know, you don't know. And it's really important that you do actually offer a genuine apology, and it's not something saying sorry for the sake of it, but actually reflecting on what has happened and understanding that, and then clarifying what's happened, and offering an apology without villainizing the person who's pointing out to you. And then learn from that, because you're going to apply what's been happening in that situation to somebody else. And you can switch this around and actually, you know, take that up with the instigator, you know, bring it up and say, actually, what you said was inappropriate. Let them have an opportunity to ask any questions and really be clear about what was offensive. Microaggressions at all? No. Okay, so I'm going to hand over to Raj, who's going to talk to you about reverse mentoring. Raj, just let me know when you're ready for me to change over the slides.
Yeah, all good to go.
Okay.
Great, thank you, Sheila. Right, yeah, thank you for those who've come today. Just to sort of briefly talk about reverse mentoring, which is a positive step to try and deal with some of the issues that Sheila has just talked about. Now, in brief, what reverse mentoring is, it's pairing junior colleagues within primary care who are from a sort of diverse background, and pairing them with a more senior colleague within the primary care system, and essentially to switch that traditional mentor-mentee role around, where the junior colleague can talk through their experiences, so talk through microaggressions, talk through, you know, their own personal experiences, and allowing our leaders to just have a better understanding of the issues and challenges that minorities can sort of face in the workplace. So often sort of some things we hear from our sort of senior leaders, you know, when they've made comments that they didn't realize it was inappropriate, or and what this is a way for sort of colleagues from a diverse background basically to talk through their experiences. Now, what we're looking to do is to recruit both mentees and mentors. So I always get a bit confused, but the mentor would be the more junior colleague. I can't really find a better word than that, basically, but the sort of who would more than likely come from an ethnic minority background. And the aim then for us is to pair them with a leader within the primary care system who would more than likely be Caucasian, and then once again build that relationship between those two, so that there's a sort of dialogue going from the more junior person to the more senior person. Now, there's a couple of QR codes on there, and I'll also post a link into the chat as well. If you click on the link, you can just sign up for it. So it's not sort of definite you have to do it, but at least you can express an interest, and then we'll be in touch with you afterwards. Now, for mentors, that's a more junior colleague, there is some training involved, and that's simply to sort of give you some tools to challenge the more senior people. There will be a couple of training sessions which are really quite helpful, and for the mentees, the more senior colleagues, there is a short session once again to just get a better understanding of what this involves. It's something that's not been tried in primary care. It's been tried many times in hospitals, mental health trusts, and local mental health trusts in Derby have tried it. Really, really good feedback. The feedback, particularly from senior management, was really, really good. So the issues that they didn't realise, what issues that they didn't realise were coming up, and just talking through it, and then actually making positive changes within the organisation to try and improve the experience of ethnic minority colleagues. Something that they've done. So primary care is a lot more diverse. Primary care is a lot more spread out. It's not based in one building or in a small building, but it's something that we think that will really help. So if you're interested, please sign up. As I said, I'll pop the link in the chat as well. You can use a QR code. I'm a bit old and I don't fully understand how these QR codes work, but I'll put the link in the chat as well. If you've got any questions, just shout.
Thanks, Raj. So just with regards to the reverse mentoring, it is a particular intervention that we've put in place for general practice after the discrimination survey from about a year or so ago. So this is really an opportunity for people within general practice, and they don't have to be clinical or non-clinical. Is that right? They can be either or. And it's really just to try and give an opportunity to build those relationships up, and give an opportunity for the junior colleagues to influence senior leaders across the system to try and help motivate and propagate change, to help reduce the issues of racial discrimination with general practice. So by having that insight and that two-way working relationship, we're really hoping that this intervention will be something that will show positive outcomes. So if you're not already signed up, I would strongly recommend that you do. If you know of any senior leaders or more junior colleagues who would potentially benefit from this, then feel free to share the resource out with them, particularly the QR codes and the links, so that we can try and help those colleagues who are potentially going to or have been facing barriers to general practice progression of careers. And like I said, this can be for those members of staff who are not necessarily clinical, so admin staff who want to potentially progress up to practice management or further kind of management leadership roles within general practice. We'll try and get people paired up appropriately. Has anybody got any questions about that for myself or for Raj? No, so if you haven't, then please do sign up. So this is really just to highlight the calendar of events. So this was our first event, and we're looking at a further 5 events over the course of the next several months, really to try and empower our colleagues with the importance of EDI concepts within day-to-day clinical practice. So the next session will be by our fantastic EDI fellow, Catherine, who will be talking about neurodiversity. So if you do want to sign up, then you can either do that through the QR code or by going up to the GP Task Force website upcoming events section to sign up for that. And that will really be focusing on neurodiverse colleagues, how to recognise the challenges they face and interventions that you can potentially put in place to help those colleagues facing particular challenges. We've got a set of events looking particularly around the LGBT plus colleagues, which will be done by one of our GP colleagues, Dr. James Betteridge-Sorbage. And then there'll be a further event around allyship and active bystander training in June, and that will really be focusing on what we can do as allies, so even as marginalised members of our communities based on race, we can actually be an ally to somebody else and have a different protected characteristic. So it applies to everybody. We can all be an ally, and also give you some really practical tips on how to be an active bystander when you're faced either with overt kind of discriminatory behaviours or microaggressions. So thank you again for all coming to today's session. If you've got any questions, I'm very happy to take them now or via email. I'm also on Twitter, and Raj will very happily answer any questions regarding the Verse Mentoring programme. You will all be sent a feedback form, so please do complete it. As I said, this is our first event of a sequence of events, so we'd really appreciate feedback with respect to what we can do to help address some of the challenges that we're facing from an EDI perspective in general practice.